Thank you, Dr. Rajesh. So next we have Dr. Grover. He needs no introduction. Sir is a Padma Shri awardee. He is a chairman at Sir Gangaram Hospital at the Department of Ophthalmology and also at Vision Eye Center. He has been a past president of AIOS, OPAI, ASOPRAS, and he has been associated with many educational society, including ICO. He has been a teacher of teachers and an inspiration to all of us. So, sir will be speaking on orbital wall defects, patient-specific implant. Over to you, sir.
Thank you, Maya. The earlier two talks have set the stage with diagnosis, principles of management. We'll talk about a specific scenario, and then Senthil will take care of our complications. Thank you, Scientific Committee, for this concept of a subspecialty day, and Fairuz for inviting us to this session. So there have been a number of realizations which have, and developments which have made a huge difference to the management of orbital fractures, improved diagnostics, improved trends, improved implants, and improved imaging being some of them. But two that I'm going to emphasize are importance of volume assessment and correction, and role of computerization, 3D imaging, modeling, and navigation, and the patient-specific implants, which have made another increased our armamentarium and made a new methodology available to us. So when you have an orbital defect, it is important to assess well what the altered anatomy is, carry out a 3D imaging and modeling, assess what the orbital volume change has been, and choose the appropriate correction in specific cases, patient-specific implants, and we'll emphasize this well when we talk about where they are indicated, and make sure that you assess what happens at the end with regard to the volume. So this is now a much greater realization that restoration of precise anatomy, precise volume is critical, and therefore the DICOM images, as was emphasized in films, with the coronal and sagittal views besides 3D reconstructions being important for our assessment. And DICOM standards have ensured that we communicate much better, we see much better the data with regard to the imaging. And this allows us to do 3D printing and modeling, which gives us a much better preoperative assessment and planning. Quantitative assessment of orbital volume is now markedly improved because you do surface rendering assisted region of interest computation. After identifying the landmarks, use the readily available softwares now for orbital volume calculation. And you can see if there is an altered volume, as in the right orbit here, as compared to the left, you can try and restore it back to the volume that the left has. So the patient-specific implants are designed based on the 3D printing and modeling, and the vendor will prepare the implant design and send it to you, including the holes, including the positions, and you have to modify it according to your clinical assessment. Because what is true for a bone model is not always so easy for a tissue with soft tissues present with other landmarks which you do not want to disturb. So there are specific indications where you need to use PSIs. There would be cases like this, like the white-eyed fractures we spoke about, where we would simply release the incarcerated contents and put in some kind of a soft implant, possibly resorbable implant. If there is a larger buckling incarceration of contents like this, we would do removal of the incarcerated contents by a hand-over-hand maneuver, see the edges of the lesion, and then go ahead with an implantation of an implant which will cover all the edges well, and that is all that you would require. This could be a EPTFE or med-POR implant or any other implant which is adequate to cover that area. But when you have large fractures with big downward displacement of contents, combined floor and medial wall fractures, especially if the inframedial strut has been affected, then it is important to have titanium implants which will provide that kind of support to the floor and to the medial strut, and to have the right angulation, as Ganga stressed so well, is very important in order to get the appropriate result. But other than these, there are those cases which are large fractures, multiple fractures, old fractures, near total loss of floor, previous failed attempts, where any corrective surgery would require a reopening up, probably refracturing, and then doing a much more complex job, which may not work well. And in these cases, patient-specific implants do well. Like this patient with severe enophthalmos had an old orbital floor fracture, medial wall fracture, lateral wall ZMC fracture, and here we thought of a patient-specific polyether ether ketone implant on a model. Then we did you need to do in these cases a very wide opening up of the periosteum and the periorbital, lifting across a large area in order to accommodate these patient-specific implants, fixate them well. Here we also did a lateral canthal disinsertion and reattachment, and we could improve the enophthalmos very significantly. This lady had gross enophthalmos as a result of her fractures, multiple fractures, and she had a dermis-lined socket. We could see the alteration in the orbital volume because of the displacements of the orbital walls, and we planned a patient-specific implant of titanium, which was placed, and we could improve her socket to a large extent, improving the appearance of enophthalmos very, very significantly in this patient. You can see the much better appearance of the supratarsal sulcus area. This patient is a particularly important situation where there has been a maxillectomy and ethmoidectomy following mucormycosis with very significant enophthalmos, downward displacement of globe, and we can see the large defect that exists for ethmoid and maxilla, resulting in this displacement. Here we did a patient-specific PEEP implant for the floor with a titanium implant for the medial wall, and we could get a much better position of the globe, much improved enophthalmos, and a much more normal-looking motility. So 3D printing and patient-specific implants allow mirroring of the fellow orbit, a better preoperative planning to allow complete walling of defects to match the contour and precise volume restoration. PEEK is an important material because it shows good biocompatibility, is visible on radiology, and has good manufacturing processes and mechanical properties. The limitations include the need for more advanced technology, higher cost, and limitation of soft tissues to accommodate implant material. Last thing, the complications. Now, this patient was done together with a plastic surgeon who also did a bone graft for the maxillectomy for a mucor excision. Here, this is the patient-specific implant put in, but he developed an exposure in this region which could not be corrected in spite of repeated efforts, and we had to remove the thing. So we have to be cautious also in these materials, but this is the only one in 19 cases that we've had a difficulty with. So you need to be cautious, you need to take care of all these issues as well. So 3D modeling, volume assessment, and patient-specific implants are a major advancement and addition to our armamentarium in appropriate cases. So newer developments like these promise an exciting future for orbital fracture management. Thank you.
Thank you so much, sir, for that lucid lecture on the patient-specific implant. One quick comment from Dr. Ganga before proceeding to the next talk.